Hi, good morning, everyone. We are on 29th of November 2025, and we are live for yet another CMAAO session. Today, our session will be focused on a very exciting and rapidly evolving domain in the modern medicine. We are talking about AI. Yes, AI in healthcare, transforming diagnostics, therapies, patients' pathway in hematology. What is AI? And AI is an artificial intelligence that continues to reshape healthcare industry and the deliveries. This topic is especially relevant for clinicals, researchers, and healthcare leaders who are looking to understand how technology can enhance their profession. We are honored to have Dr. Chakrabarti as our distinguished speaker for this session. Dr. Chakrabarti is currently serving as a Chief Medical Officer at Sugah Healthcare Corp, Zoho, Chennai, Tamil Nadu, and as a professor at Shri University, Cuttack. He's also the founder and CEO of Chhoo Mentor Academy, which continues to nurture innovation, clinical excellence, and leader in healthcare. With his distinguished expertise across the medical practice, healthcare technology, academic leadership, Dr. Chakrabarti will guide us today how AI is redefining the technology, the diagnostics, and the healthcare sector. Sir, over to you.
Yeah, thank you and welcome everyone. I will just share my slide set and let me know whether you can see it. Is it visible?
Not yet, sir.
Okay, let us wait. Let me see what is happening. Just a second.
Yes, now we can see the slide. You can put it on.
Yeah. Thank you. So, we healthcare providers are still behaving as if, it's a newborn and we will wait to see those and all. But I'll try to give you a perspective as we fit in it. So I actually live in a village in Tenkasi, Tamil Nadu, which is the global headquarters of Zoho Corporation. And I bring you greetings from there. Today, what we will discuss is obviously what is AI, especially from the clinician's perspective, from the lab diagnostic perspective. What are the generations of AI using it in hematology today, be it for diagnostics, patient care, and others. So as we know, anything artificial is a copy of human intelligence. So obviously, this is also a copy. We still do not know whether it's a good copy because we don't understand the human brain's function, but we are trying to reproduce it. But we have given this capacity to the machines, and we humans only have given it, is to memorize and learn from experience. That is how we conduct our exams. But we are now enabling the machines to think, create, speak, maybe create good video films, judge and make decisions, which makes it the most powerful tool, whatever you have seen till date. So you have to understand this entire artificial intelligence is basically harboring many subsets within it, like machine learning, deep learning, and then within it came generative AI, which everyone knows as, Chat GPT, and then you have Gemini and Anthropic. You have these models sitting there. We will do a ramp walk. And so Chat GPT is just only a part of it. Remember, it's a user interface for using that model. So when I talk of generations of AI, it's not like, the generations of iPhones. It is much more complex and empowering at the same time. So AI started when most of us were not even born, right? In the 1950s. At that time, it followed directly encoded rules. So if then, and so an expert would code and then it could do it. With that kind of AI developed so many years back, IBM's Deep Blue actually beat Kasparov. And in healthcare, even today, we used rule-based clinical decision support tools. We call it CDSS, and these are still being used. The only problem here is that if the human who is developing it has logic errors and bias, they get encoded in the rules, so they might not work well in real world situations, but they were doing a decent job. Then came the first decade of this century when we developed what we now call as deep learning. So previously you could just ask it, is this a picture of a cat or a dog? Now you can ask it that how many dogs will be in the park in front of my house at noon, because it can look at all the data, it can retrain itself and tell you. And this is where a major evolution occurred, and you'll see a lot of things in social media like Google's diabetic retinopathy detection, breast cancer, lung cancer screening, skin condition classification, even prediction based on electronic health records as to who will go home and who has a high chance of fatality or severe comorbidity. In fact, whatever you're using in your phone now in terms of automated text generation while you type the first word, and then voice to text, and then language translation, these are all AI 2.0. The only problem with this generation is it has some out of distribution problem because real-time data often differs from training data. And it is a typical characteristic which we call catastrophic forgetting, right? So it does not remember early parts of a long sequence of tests. And again, the bias which I discussed in 1.0, that has remained. And then came 2018, the foundational models, and which were accelerated during COVID, which can generate new content, perform different types of tasks without new data or retraining. So, it's like an unsupervised intern, but it has some self-supervision. So now it can not only tell you how many dogs and cats will be in the park at noon, but it can tell you the difference between a cat and dog. But the problem is if you ask it, how does it know? It will not be able to tell you now. So even the agentic chatbots and all are all based on foundational models. In healthcare, you specifically have MedPalm and MedPalm 2 from Google. You now have medically tuned large language models like PubMed GPT, BioGPT, and obviously the others like Grok, Plot, they are doing it. But now what have we introduced? The bias was there, but now we have introduced something called hallucination. That means these models are confidently wrong. You ask them an information, the first thing is it will say, great question. Then it will give you an answer, it will give you references. Reject the references, most of them will not exist. So when I do a review of anything, it gives 5 references of my publications, which I have never done. So you have to understand that just as an alcoholic, it is confidently wrong and you have to be very careful. So what happened was that when deep learning came in, the important difference with machine learning was that machine learning was just doing feature extraction, feature selection, and classification. Here we were using a convolutional neural kind of network where it actually requires powerful GPUs, and it does not need to understand the best features that represent the data. So, but what it interprets and how it gives it obviously is a big problem. Most important you have to understand is, as healthcare providers, we are the primary data scientists. And if we do not record original correct data, then these models will all flunk. So data collection and pre-processing is most important. Then you can select a model. There are so many in the open source domain. Then you have to train those models, and then you have to do something which is very important, which we coders call it as hyperparameter tuning, so that it does not overfit. Like you give it data of say 20 patients, and then you use it for 20,000 patients. It will give you answers, but most of those answers will be wrong because it will overfit. So both the quality and quantity of data matter. We hematologists actually are trying to generate awareness about AI for quite some time. And this is from the British Journal of Hematology, where we clearly explain what is supervised learning, what is unsupervised learning, and what is reinforcement. So supervised learning is what the interns should undertake, right? So there should be a teacher who would supervise how the intern learns. Unsupervised is unfortunately what is happening in most of the medical colleges. So they try to identify patterns and groupings, but in AI, it is more about pattern recognition. And if you have to combine these two, you can do what we call as learning. So you optimize prediction by trial and error. So if they're right, they get a positive reinforcement. If they're wrong, they get a negative reinforcement. These are all what you'll see in publications nowadays, like support vector machines, random forest, K nearest neighbors, convolutional neural network, graph convolutional neural network, and all these things. Now you have to understand that these are all our efforts at copying how our human brain acts, but it has a lot of statistics inside it. So these are the basic statistics models. You don't have to actually learn all these models, but you have to understand what are the limitations of them. That's why I'm just showing you. And then we use, I told you about hyperparameter tuning. There are also certain feature normalization techniques, which are essentially statistical tools. Now we use the machines to do it. So there have been two distinct eras of computational usage in training AI. Initially, we had the Moore's law, where we said that the technology doubles every 2 years and the cost becomes half. It was going like this, but look at what happened in 2010. Now the curve is steep like this, and look at the processing speeds, 1 E plus 4 petaflops per second. And when quantum computing comes, you cannot even imagine the kind of progress we'll be doing. Now, that is why you'll see that when AlexNet and GoogleNet were there, we were going slow. But now it's all about AlphaGo Zero, and every day you hear about quantum computing. So many places I go, they ask me whether all these algorithms and machines will replace us. You have to understand, as far as visual interpretation and vocal interpretation is concerned, they have already beaten us around 2015. That means if you talk to a human and if you talk to a machine, the machine does better. This is already 10 years back. But have they replaced us? No, because there are so many nuances and we have to take care of them. So even these large language models were started way back in 1967, and then Stanford was there. Google Transformer architecture was already there in 2017, but the hype was created by OpenAI when they launched GPT-3, and now we are awaiting the launch of GPT-5. So what kind of data do they analyze in terms of billions of parameters? So GPT-3, they never tell the truth, but it's somewhere around 175 billion parameters. Megatron Turing NLG's graphs, 530 billion. We are slowly trying to now approach around 0.8 trillion. But if you consider the neonate's human brain, that can analyze 10 to 100 trillion parameters in a human brain. So never underestimate your own brain, right? Okay, they can read text, images, speech, video, structured, unstructured data, 3D signals from all sensors. They can answer questions. They can do your sentiment analysis. They can take out the relevant information. They can even tell what a picture is saying. It can recognize an object. But can it think like a human? So even after ChatGPT passed the Turing test, that means a human could not distinguish whether he was answering it or a human was answering it. It performed just like a 9-year-old in the theory of mind, which is a kind of reasoning ability. So when it first released its O1, there was a lot of hype about it, with reasoning abilities. But as physicians, we need to understand what are the different types of reasoning AI does. Some of this the humans also do. So you have deductive, inductive, abductive, analogical, even common sense, which is not that common. And then you have monotonic and non-monotonic. And then you have fuzzy logic, which is all over the place in your washing machines and others. And they're slowly being incorporated into healthcare. So what is deductive? This was AI version 1. If there is a presence of certain symptoms, it matches a known pattern, it gives you a diagnosis, right? This is what we also do, but it all depends whether those patterns are already loaded. So what is inductive reasoning? It can analyze large data sets of specific observations, like say patient symptoms, test results, and it then finds patterns and then makes broader probabilistic conclusions, which is akin to say weather forecasting, right? This is what inductive is. Now, what is abductive? Nothing about kidnapping. It generates the most plausible explanation for a patient's symptoms by forming and evaluating hypotheses against the observed data like symptoms and medical history. So it's a kind of Bayesian thinking where it looks at those symptoms, it looks at the results, and then it generates certain hypotheses and gives it weightage. This is exactly how a doctor thinks. Then you have what is called analogical thinking. So here you have case-based reasoning systems where it has similar case reports all in its database, and it solves new patient problems by drawing parallels. Like we use PubMed to look at case reports and diagnose our patients. But what is common sense, right? Does AI have common sense? Yes. It is being empowered to understand context, make inferences, and interpret situations beyond the raw data. So suppose it comes to know that a patient is feeling dizzy and he's a diabetic and he has missed his breakfast, it would automatically deduce that here it is probably not AMI. The chance is more of it being a hypoglycemia. So that is what common sense reasoning is in AI. Now, what is monopony? Monotonic is that it will not change. There are some truths, though medicine does not have any laws. But if the blood pressure today is above 140/90, it is hypertension. It does not change it unless someone feels that it has to be changed. But what is non-monotonic reasoning? It can handle incomplete or evolving information, allowing systems to revise the diagnosis. So from the symptoms, it says, oh, I think the patient has common cold. Then it is fed the chest x-ray. And then it says, oh, no, this is serious. This patient has pneumonia. So that is what is non-monotonic reasoning in AI. Now, fuzzy logic, as I was telling you, is it processes large structured data sets, and where we are using it today in medicine is in medical imaging analysis, be it chest x-rays, other x-rays, CTs, MRI, and then it can do some predictive modeling and it can automate your administrative tasks so to be creative. So as you see, the current models which have been launched, including OI or Group 3 Reasoning Beta or O3 Mini, they actually have significant reasoning model shown in violet. So which era are we now? So just like DC and AD, We say before ChatGPT was DC and after DeepSeek, it is AD. Why? Why is DeepSeek so different? If you go back, you look at this, that it is doing great job in reasoning, but it does not need very expensive, high throughput GPUs. So that is why we call it AD. So what is happening actually in healthcare? If you look at, first of all, as I told you, it gets all the data. So there is better data-driven decision and automated data analysis for screening from imaging, image segmentation. Then you develop certain biomarkers, combined with it some blood parameters, urine parameters, and you do an automated detection. You can also do a good prognostication, risk stratification of disease, and then you can do cancer detection, monitoring, progression. And on top of that, we are going slowly towards personalized cancer therapy. Not one size fits all, and it's not about carpet bombing like Intel. Now, you have to understand that AI cannot work in a silo, in isolation. It relies on big data. So where from does this big data come from? Right? It is coming from genomics, because now you have next generation sequencing at a reasonable cost. It is coming from the epigenetic data, methylation, demethylation. It is coming from the proteomic data using Maldiv and all other platforms. So you exactly know after the gene gives the signal what happens to the protein, how the transcriptomics is working. But most important for us, it gets data from electronic health records and electronic medical records. So if you're not using it, where will it learn from? Where will it get the big data from? But I've told you about so many omics. Now the in thing is exosomic, exposomics. So exposome is whatever you're exposed to right from your mother's womb till your death. And there is an environmental exposure and there is a humanistic exposure. So humanistic exposure is the socio-economic, lifestyle, psychological, how anxious you are, what kind of food you're taking, what is your work stress, and environmental is both internal and external environment. This kind of big data come other than AI, no one will be able to interpret it. So there are challenges here. We are trying to do exposome data engineering and spatio-temporal aggregation, time series, exposome health association, because our ultimate aim is disease prediction and prevention. But there are also certain small sample learning models which looks at the big data, remains within your institution, and then tries to do it. So it is all about data collection, feature extraction, data splicing, model construction, and application. And this again goes back and helps in data collection. So all the technologies together are actually working. They are working for drug discovery, immunotherapy, patient data management. But remember, all of them have to be robust and safe. Now the question that why AI in hemato-oncology? Because hemato-oncology or hematology in particular stands as one of the most data-intensive medical specialties. It generates vast amounts of information from peripheral blood smear, from flow cytometry, from next-generation sequencing, and even from multi-omic analysis. So this wealth of data actually presents a challenge, but it also gives us an opportunity for the modern clinicians. And where does these diagnosticians face a problem? Cognitive fatigue. If you're having long microscopy sessions, any brain will get fatigued, and you're doing routine work. And then no two hematopathologists can agree on a particular diagnosis. It has been proven multiple times. So even World Health Organization has its own classification, International Cancer Congress has its own classification, and within it, you will see that they say ultimately they went into a consensus, but there was some discordant data. And there are a lot of time constraints when processing complex data sets. So these challenges become particularly acute when dealing with rare cell populations, even rare diseases or subtle morphological changes. Now you're doing single gene sequencing. So imagine the kind of data what you are doing. Now, whatever I could make you understand about artificial intelligence, you must have understood that it is very good at pattern recognition, at high dimensional processing, and multi-dimensional integration is what it is capable of. And that's why it does well in predictive analysis, prognostic biomarkers, treatment response. The entire patient pathway can be better if it has certain data. But the critical principle you all have to remember is that it augments rather than replaces clinician. It's a powerful diagnostic adjunct. It enhances human expertise, but you have to preserve the irreplaceable clinical judgment that defines quality patient care. Now, as I showed you the generations of AI, what were we doing in hematology? In 1980s, we have already developed image processing software, automated blood cell morphology. There are European versions. There are now Indian versions, which can assist cytologists in differentiating different types of leukocytes and other abnormal cells. In the last century, we developed rule-based expert systems in laboratory medicine. This I'm talking only of diagnostic hematology, right? And then 2010, when you got those machine learning, SVMs, gradient boosting, so non-linear biological data, along with proteomic, transcriptomic data. And then with deep learning, with the convolutional neural network, they have started outperforming pathologists in classifying bone marrow aspirates and medical images, but don't feel threatened. No, they will do some things good, they will do some things bad. Human in the loop is the most important strategy. And today, the generative AI models actually simulate new molecular structures. They synthesize training data. So it's very good for training the future hematologist also, and they can generate explainable insights for precision medicine. But there are certain black boxes there. So this is from an article published in Blood Advances on 6 November. These are the terminologies we are now using. So you might be thinking, what is agentic AI? They are capable of autonomous decision making, self-directed goal setting. They can work on your behalf, but then it can commit mistakes also. So if I want to demonstrate the difference between machine learning in hematology, deep learning in hematology, machine learning will go through the joint ultrasound images. They will extract the features into algorithms, classify them into patterns, and say whether there has been a bleed or not. Deep learning actually uses neural networks to perform that same task. Sometimes it is better, sometimes it is worse. So in digital morphology, digital microscopes have transformed, like YOLO V10 model now demonstrate exceptional performance metrics, 96.85% accuracy, 96.76% F1 score, 12 distinct white blood cell types. So especially in the districts where you do not have trained pathologists or even good trained technicians, this can create the difference. Even for bone marrow morphology, it can not only diagnose leukemias and other blood cancers, it can also say what is the degree of fibrosis, which even, expert hematologists need some years to learn. And it's a Cohen's kappa coefficient of 0.83. Obviously, nothing is 100%. And then now you have vision language models such as CLIP and MedClip, which generates draft pathology reports by looking at the images, reading the history, reading whatever this systems have generated, and then there is a comprehensive report being generated. Now, flow cytometry is all about data and numbers. So here AI has been in a major role for the last 30 years. So there's a company called BD, they are leaders in flow cytometry. Last year, they have acquired 27 AI startups. So you can imagine what they want to do. You can use 40 different fluorescent colors. You can even do unsupervised clone discovery, like FlowZone or, neighbor embedding technologies, automated gating, because gating is so difficult. You cannot get good flow cytometries even in the major metropolitan cities now in India. And as far as minimal residual disease is concerned or measurable disease, it can detect 1 in 10 to the power of 6 cells. So that is the capability. I'm just showing you this review article. You can read it to understand how we have developed it. This is already 2 years old, but it shows you how the gating is done. And if I, on the left side of mine is the manual gating, on the right side is the automatic gating done by the AI-based machine learning. You cannot even detect a difference. So you just have to run the sample even in a district hospital, upload it, AI will do the basic triage, and then one cytometrist sitting somewhere, flow cytometrist will do. Similarly, it has revolutionized cytogenetics and karyotyping because these are also very monotonous and tedious works. Cytogenetics requires at least 20 years to become an expert. So now you have state-of-the-art transformer-based karyotype systems trained on databases like 50,000 images, which does a lot of work. In solid tumors, now where there's blood flows everywhere, so we already had it. Even liquid biopsy is now helping us to look at circulating tumor cells. AI is helping us in signal enhancement, multimodal fusion, and detecting relapse 4 to 8 weeks before conventional methods. Obviously, this is still experimental. It has a 75% sensitivity, but 98% specificity. We are also trying to integrate our genomic laboratory imaging data with the radiology. So multiomics is a truth today in leukemia and lymphoma. I talked about graph neural networks, graph attention networks, graph transformer networks. All these are already available to every hematologist, and they can start validating it and collaborating. Single cell AI analysis helps us in understanding clone evolution. And we are using it to integrate the big data for precision medicine in AML, which is one of the most difficult diseases to treat. So you take only 30 AML patients, look at their drug sensitivity, look at their expression, and then you look at how you can use different targeted therapies, positive association, negative association, flow it through AI. When quantum machine learning is coming in, Google claims it is already there. I think within 1 year, you'll see quantum computing in healthcare in a big way. We are already using QProteoML in multiple myeloma. So we call it QPCA, QSVM. It performs classical machine learning, but it can detect drug resistance pattern and early relapse far ahead of time. Now, here is a question for all of you. You can share your opinion in the chat box. Can you diagnose acute leukemias without using a microscope? That means without looking at the peripheral blood smear. What is your opinion? Is it possible or impossible? Let me show you. We have already developed and evaluated a machine learning model based on certain parameters which are generated by our automated cell counters and our automated biochemistry analyzers. Simple things like fibrinogen, MCV, prothrombin time, LDH, percentage of monocytes, mean corpuscular hemoglobin concentration, age, lymphocyte count, absolute monocyte count, and platelets. It can differentiate between AML, ALL, and acute promyelocytic. Only 10 routine laboratory parameters. It's an accessible technology because you can place these machines even in district hospitals in India. And it can do a rapid triage and it can help us in optimizing resources. The best part of it is an open source. It can democratize advanced diagnostics even when you don't have a pathologist or a good technician. I consider it as a game changer. It is called as acute leukemia prediction system using AI. It can help guide urgent therapies in settings in the emergency so that APML will use them in the first 7 days. You do not waste time. Diagnosed, send them to a referral center and management. So multimodal transformers are the future. There is one Maria, right? That's an acronym for multimodal artificial intelligence for hematologic assessment. This is the approach where everything matters. Clinical history, laboratory parameters, images, and then it generates a specific algorithm, looks at it, and helps you. So in today's hematology, clinical data is coming in, radiology is coming in, histopathology is coming in, NGS is coming in. We are classifying diseases, we are predicting outcomes. So the prognostic scores are changing. Now there are AI-based prognostic scores like in MDS and others. And we are generating digital twins of the patients. So if the entire journey is captured, we can predict what is going to happen. So if I look at hematology diagnostics in 2025, you have cytomorphology, you have flow cytometry and cytogenetics, automated image data processing. This is already a truth. Now, if a lab is not using it, it is wasting its resources, but it has to undergo quality control. So what are the considerations for clinicians? The most important consideration is in your rush to use it, do not compromise the privacy of your data. What is federated learning? Means your data remains within your institution, within your system. Anonymized things go and then they teach the system. It's just like Google Maps. When you see a red road, you cannot identify whoever given it, but it shows that there are so many cars stalled there that that road is now congested. Model calibration. And this model calibration cannot be done by engineers. It has to be done by clinicians. And then you cannot use black boxes like OpenAI and Gemini and others today because you have to sign the reports. You have to take a treatment decision. So we are trying to incorporate explainability tools. Regulatory compliance is important. You have even in India now software as a medical device, but they need good clinical validation. ICMR has already established in India a National Institute of Digital Health and Governance, which is looking into this. You have to integrate into the systems. So your system should be ready. If your staining is not good, if your basic systems are not well calibrated, it will only be garbage in, garbage out. And I call it garbage in, harm out, because it is healthcare. You'll be harming people. That's why you need human AI co-validation. And that is where we always talk of human in the loop model. So what are the challenges? Biases. And I think our Prime Minister in Paris gave a very beautiful example that you tell a model to generate a picture of a person writing with the left hand. 99.9% times it still generates an image with someone writing with the right hand. Why? Because that is the bias of training. Generalizability gaps are there, black box concerns, especially if you ask Sam Altman today, how is OpenAI giving me this answer? They say we do not. No, that cannot happen in healthcare. So it has to be explainable. A lot has to be done about cybersecurity and privacy. Do not be over-reliant on this because the manufacturers to earn money will promise you the sun and the moon. You have to be skeptical. There are medical legal uncertainties also because the patient cannot sue the algorithm of the machine. It will sue you. But don't worry. Now the DPDP Act has also been notified. The AI Governance Act has been notified in India. So it is transforming every year. 96.85% diagnostic accuracy has been already achieved. 10 to the power of -6 MRT sensitivity, 4 to 8 weeks earlier detection. 99% of the times it can detect a single cancer stem cell. And this is the future which has just started. I think it has been born 2 to 3 years back, integrating previously siloed data streams. So clinical narratives, and there you have ambient scribes. You keep on talking with the patient, it actually generates a structured medical note. They are already there. Laboratory time series, digital pathology, flow cytometry, genomics, imaging, PET CT, and then you get. And what is the real world impact? Like AI file I showed you, peripheral hospitals can diagnose leukemias within minutes. It will improve the efficiency of a reference laboratory. Molecular laboratories are already using it for NGS. Clinical decision support becomes better, and you can longitudinally monitor if through, say, we have ABDM, where we have an ABHA ID in India, the entire data is supposed to be captured. So we are trying to break the geographic barriers and reduce the diagnostic delays. But where is hematology? This is what I downloaded last week from the US FDA website. Out of 1,248, more than 900 are in radiology. Hematology is here. Pathology, oh, it's here. So let us remove the big data of radiology, and then you'll see hematology and pathology. They are right now only FDA approved, less than 20 AI applications. So we still have a long way to go. What will we do in the next decade? We will clinically validate and deploy. We will standardize and scale it, and clinicians have to play an important role. And then by 2035, you can get a precision medicine at scale. So, dear friends, AI can transform every diagnostic layer and help in therapy also, but it is an augmentation, not a replacement. Multimodal integration represents the future. Implementation requires thoughtful approaches, good vision, and collaboration. The hematologist, or in fact, any clinician, has to be AI literate, because otherwise the technology will fool you. This is what we are doing right now. Patient specimens, clinical information, multi-omic panel. You can then predict it, prognosticate it, and diagnose it. This is a visual abstract from the review article, which shows you in drug development, in diagnosis, in prognosis, treatment, and research, there has been a revolution. We can't deny it, but we have to critically evaluate them. We have to collaborate with the other disciplines. So as I always say, please don't leave it to the engineers. Please don't leave it to the CEOs who are running after profits. You have to have a fair play. And that's why clinicians should take a leadership. And if you're interested, we have recently published a book in India, and I've written the chapter on hematology and oncology. You can scan this QR code and get in touch with me through various platforms, and would be lovely to answer your questions.
Dr. Chakrabarti, thank you so much. I think it was extremely knowledgeable information about the artificial intelligence. I know we are working a lot of things on, artificial intelligence, including in the medical and healthcare sector. I personally remember I was working with somebody in Canada for CT scans and MRIs, where they are uploading the images on the cloud, and the artificial intelligence will help us to figure out where exactly, how strong is the heart, where exactly the problems will come in later. So a lot of things are involved. I have invited some of them on this presentation later, not today, but with this note, we would like to open the question answers. We have Dr. Chong here, and we have Dr. Kakri here. Dr. Kakri is the president. Dr. Chong is the chairman. Before I can invite Dr. Chong, can I have Dr. Kakri here if he's still available? Dr. Karki?
Yeah,
Yes, sir.
good morning. Yep. On behalf of CMAAO, I thank you and the speaker for the fruitful discussions, presentation about AI in medicine. This is a very important topic, and especially for nations like developing nations, it's really challenging. I hope, and since it was focused on hematology, I agree, AI has not been put. I hope we will have more discussions after this question answer sessions will be more fruitful. And thank you for having us here. And thank you, speaker.
That was Dr. Anil Karki. He is the president of CMAAO. Dr. Chang, please take over.
Thank you, Sarah. And thank you, President, for your message for all of us. Welcome. And Dr. Chakrabarti, thank you very much for that wonderful presentation. I just have a question. This agentic change that they talk about will probably result in a lot of job restructuring, loss of jobs, etc. Do you see any major impact of AI for the medical sector?
Yeah, so that's a good question because everywhere I go, people ask me, will it replace us? Now we have to realize in a country like India, you have a significant population who never come in contact with a physician throughout their life. So if there is something which can help them, I look it as a positive employment generation. I'll tell you why. Right now, I am doing a piloting where you have certain point of care diagnosis at the village, and you have a trained human who is interested. Need not be a trained doctor, need not even be a trained nurse, who can be the buffer between that human, that point of care, and maybe a teleconsultant specialist sitting somewhere in a city. So all those things, if they're used correctly, new types of jobs can be generated. But obviously, if you talk of receptionists and other things, they might lose their jobs because we are already seeing it in the healthcare sector that agents are doing. Sometimes they're not doing a good job. But one good thing in healthcare is humans want the human touch. So even if it's agentic, you have to place someone, because I've used the agentic AIs for airlines also. Ultimately, they are hopeless, right? Whenever you have a specific problem, they will then take you to a human. But I feel that when they slowly learn, they will do it. And I'll give you the flip side of it. Recently, I worked with Sridhar Vengu and he tweeted, so there was some confidential data shared, and then it was said, sorry, the agentic AI is saying sorry. But actually, whether it's the agentic AI or the human, you never know. So humans may blame the agents for all the errors, and then you do not know whom to blame. But yeah, I strongly have suspicions that routine kind of jobs might be lost. But I think it is time to reskill those same people and then take them in, because healthcare itself will grow. It is just that whether we can keep it safe and then it can improve the quality. But I think safety is our utmost concern at this point of time.
Yes. Also, the other big aspect about AI in medicine is the medical legal implications, right? As you mentioned in your talk, that you can't really sign off on an AI, right? Or an AI can't sign off on itself and bear medical liability.
Yeah.
So you still need a human to bear medical liability and legal liability and be accountable. So accountability, medical liability is still it's still something that
and
will stop.
it has to be also in terms of governance. So we are trying to bring out a white paper. What is ethical AI, right? Because even within organization, we are seeing that they're saying, no, we are using it. I say, where is the validation? And what happens if it misleads you, which it can confidently do? I mean, all of us who have used it know how confidently wrong it is. So obviously, those are the emerging frontiers. But what I feel is that we clinicians should not leave the leadership space to others. If we do it, we will suffer. So that is one important thing all over the world. I actually request all the healthcare providers, even the nurses, even the medtechs, that they should not leave the space just to the technology or the technologists. This is my humble request.
I also, when I use AI sometimes to search for certain things, I find that the way I question the AI is critical. But the problem is that the layman can't question it the way we question an AI on a medical topic, because we will be questioning with a certain kind of thinking, and we question the AI with a certain kind of thinking, then we come up with a very, very good outcome. But if a layman doesn't understand how to question the AI, then it doesn't derive the value so you need some thinking in your brain before you actually use the AI.
Absolutely. So, even when those other courses came in, like Coursera and others, we realized that it was not helping the people. It was helping experts who had some knowledge and they were helping it. Here also, it's the same thing. So when a patient comes to me that ChatGPT has told me this, I said, see, you have to understand that ChatGPT is a friend sitting by my side, but it can be an enemy to you depending on the kind of illiteracy you have. So be very careful, right?
So we can see how powerful a tool it is, because we will know how to question ChatGPT on a medical topic, whereas a layman would not know how to, and we'll be able to derive the biggest value from a ChatGPT questioning.
Absolutely.
Yes, I think these are some of the issues that we are all struggling with in AI. It's not exactly, and of course, I also worry about whether any of my proprietary reports and so on, because I write a lot of reports for my patients. I also worry whether this will be sucked up into the cloud, like a lawyer worries about his format and his templates being sucked up into the AI cloud.
Yeah.
And then he loses all the proprietary.
That is why I talked of federated learning. Federated learning is supposed to take care of that. And now in India also, just like GDPR and HIPAA, we have a DPDP also. So we have to be very careful. Even when you use ChatGPT, if you go to the settings, you can, at least, I don't know how much they are lying or they're truthful about it, that you can say that don't use my data to train the system, right?
Yeah.
And if you have to do it, it has to be in a totally anonymized layer. So now even the LLMs are good at coding all those. So, but remember, it does not forget anything.
Yeah.
So if I tell it to forget also, and then I ask it, okay, what did I ask you to forget? It will tell, oh, you asked me to forget your name. And your name is this. So it never.
Dr. Ashraf, Prof. Ashraf, you have a question?
Yeah, thank you very much. Thank you very much, Chakrabarti. It is an excellent presentation indeed. I appreciate your approach, and particularly the last slide, that these are the sportive tool AI or whatsoever we were doing in the start of the history of all the medical sciences, starting from the X-rays, ultrasound, and modern technologies what we have. Still, I believe and I appreciate and I stand with your opinion, what you have said, that it is a sportive tool to the medical profession and to the doctors. Ultimately, the doctor has to decide and doctor has to understand what is necessary and needed for the patient's care. And I think that is a very good message, what I have took. But at the same time, I will say that AI is now going to help us out. But at the same time, I'm afraid that they are going to disable us, the thinking process to the humans and even to the doctor. Thank you very much for giving me this opportunity, Chairman.
Thank you, Prof, for your insightful thoughts. And any other questions from the floor for Dr. Chakrabarti? Well, if no questions, I'd like to thank Dr. Chakrabarti for his wonderful presentation. And it's always good to have a good insight into a topic which is so hot now, and really it's in our face, whether we like it or not. It's right in our face. And whether we like it or not, the patients will also push it in our face. So thank you very much for that wonderful discussion and and presentation, and we really benefited and enjoyed it very much. Thank you so much.
Thank you, Dr. Chakrabarti. Any take-home message you have for our audience?
No, the take-home message is very clear that when you could learn 22 subjects already, this is another subject which you need to learn, right?
Yeah.
You cannot keep it that, others will do it and we will use it. I'm not asking you to learn logic which you are going to use. So I think we need AI literate physicians all over the world. And that is where, such awareness sessions and others can help us. Please read and play with it. Play with it, you'll understand it better.
Perfect. So I think with this note, we would like to end this wonderful session. Thank you, Dr. Chakrabarti, for enlightening us with the AI knowledge. And with this note, we would like to end the session. We will again be back with another session, another week. Thank you so much till then.
आप हमारे साथ हो. Are you excited?